Hello, everybody. It's Mrs. Bartels. I'm going to do the chapter 30 lecture for you. This will be the lecture that was for Monday and also today, the 25th and 26th. It's the entire chapter, chapter 30. Okay, I'm going to click on the PowerPoints. So, chapter 30 is all about oxygen and breathing. Chapter 25 that we just finished talked about temperature, pulse, respiration, blood pressure, which are the vital signs on a patient. Then height, weight, and pain. So now we're going to go a little bit deeper and explore and learn about respirations and the oxygen in a person's body. So oxygen is vital. We need oxygen to live. If we do not have oxygen, our organs can shut down and we can have brain damage and eventually die. So oxygen is essential. Our brain is very sensitive to oxygen. If we don't have enough oxygen, the first signs that somebody is not getting enough oxygen exchange for their cells or their body to work is usually confusion and disorientation, or behavioral changes. Okay, so let's get going here. So here is a picture of Mr. Oxygen. He's kind of cute. This supposed to be like a red blood cell. Your blood needs oxygen. The job of your heart is to pump the blood, and the blood has oxygen that gets out to all your cells. Okay, so this is a little red blood cell. He is pushed out of your heart, and when he comes out of your heart, he has oxygen. He's going to travel all around your body and deliver oxygen. And then the parts that he delivers it to will give him carbon dioxide to go back to the lung and make that change into oxygen again. So he basically delivers oxygen, brings carbon dioxide, the bad stuff back. The lung then changes it back to oxygen and goes out again. Okay, so it's just the heart and lungs working together to exchange your oxygen. So oxygen is pretty cool. We have to have it to survive, but yet it's very tricky. We don't even see it. We can't taste it. It has no odor. It has no color, but yet it's a basic life need. If we don't have it, we're going to die. So it's kind of a mysterious thing. It's in the air and you don't even know it. It's not like you see oxygen floating past you. If a person stops breathing, within minutes, there's starting to be organ damage and brain damage, and then eventually death. Okay, so we cannot go long without oxygen. You see this very commonly in a drowning patient. When you go to pull them out of the water, you might have to start CPR, and then they might come through and start breathing on their own and get their heart going. But then the question is, how much damage is done internally? Do they have brain damage or not? So usually that's how they decide too. If it's a drowning victim that was really bad, they put them on life support, and then they'll do CT scan or MRI to see how much brain damage there is. We see it a lot with kids that might drown, accidental drownings, and the parents are holding on for dear life because they just want their kids to survive. So maybe that baby or that kid is put on a ventilator, and they will do an MRI or a CAT scan to see what is the brain function of the patient. How bad are they damaged? Okay. So when somebody doesn't have a normal respiratory function, they're not breathing normally, it's called hypoxia. It means your body is not getting enough oxygen for its cells. I told you earlier, the early signs include restlessness, dizziness, agitation, behavioral and disorientation, behavioral changes. So the patients, when they're not getting enough oxygen, starts to act a little cuckoo for Cocoa Puffs. They get very restless. They have a hard time following directions. They will have a little bit of agitation. They might complain of being dizzy. So these are early signs. They are on your test. Make sure you know them. They're on the first page of your book on chapter 30, page 441, I believe. Okay. And then if they start turning blue or they're having increased respiratory rates and change in pattern, that's a later sign. So adults normally have 12 to 20 respirations a minute. We already know that from the previous chapter, and the respirations are quiet, effortless, and regular. Both sides of the chest rise, fall, rise, fall, rise, fall. Okay, meaning quiet. If I stop for a minute, I'm breathing. I just took 3 breaths in, but you didn't hear them. And you didn't hear me working hard. It was effortlessly for me. Okay, so that's what we mean normal is. The following are abnormal breathing patterns: tachypnea, Tachy means fast, penia means breathing. So this is fast breathing, meaning a person's rate is greater than 20. Bradypnea is slow. Brady means slow, penia means breathing. So again, this person's breathing too slow. Their rate is less than 20. Less than 12. Apnea is when they're not breathing at all. So A in front of a word means absence. Penia means breathing. Absence of breathing. Dyspnea, dys means difficulty. Penia means breathing. So they're having a hard time breathing. Orthopnea, ortho is a position. So this is the kind of person that likes to sit up to breathe. They can't lay flat. They do not like to be flat. They don't breathe well flat. They like to sit high, sit up in the bed, or sit in a chair, or sit in a recliner. Okay, so orthopnea. Then you also need to know chain stoking. Chain stoking is usually at the end of a stage of life, or when somebody's in hospice, they're getting ready to pass, so they'll chain stoke. It's where they breathe very fast. It's like, okay, so it's fast breathing, then it goes slow breathing, and it goes no breathing. And then they pick it back up. So I'm going to do it again. Remember, it's fast, slow, no. So here's what it sounds like. See? So it's fast and slow. Okay. These are just going over the terms again. So remember, tachy is slow, brady is fast, apnea is none. We don't need to know hypo and hyper. You can skip those guys. Dyspnea, dys means difficulty breathing. Chains is the one I just did. Fast, slow is stop. You're like, is he dead? What's going on? Because you think they passed, and then all of a sudden they gasp and they grab air again. And they do know the breathing episodes. So if you think somebody is not breathing normally, I would wait the whole minutes before you go running out the door and screaming, oh my God, the patient's not breathing. Okay, watch that breathing for a whole minutes. We talked about orthopnea. Kussmaus, I'll show you a picture. We see this more commonly in kids, especially kids that are uncontrolled diabetics and are distressed because their levels are too high, their blood sugar levels are too high, or in respiratory kids, like with really bad bronchitis or pneumonias. So how do we know the person's pulse or their person's oxygen's okay? They might say they're short of breath, but they don't have any of these signs we're talking about. They're not breathing fast. They're not irritated. They're not making, they're making sense when they talk. So maybe they say they're short of breath, but they're not really showing any of the symptoms that are on page 442. Those are symptoms you would have to report to your nurse in the blue box. The restlessness, the disorientation, the confusion, unable to follow commands, pulses increase, cyanosis. What if your person doesn't have any of that, but you think there's something wrong? We could use a pulse oximetry, which is a monitor that goes on the person's finger. It's the most common spot. It tells us a number on top and the pulse on the bottom. This number tells us how much oxygen percentage is actually in our blood. Okay? You want it to be between 95 and 100. If it's not, if it's below 95, you can't put oxygen on the person, but you need to let the nurse know because it's a drug. You guys can't put oxygen on, only the nurse can. So if somebody's 93, you might want to put the collar on so the nurse comes in. You can have the person sit tall in the bed, encourage them to slow, deep breathe, and maybe even encourage to cough to try to clear their throat and clear their lungs. And that number might go back up. If not, the nurse will decide what's next to do. The sensor doesn't only go to the finger, it can go to the toe, the earlobe, the nose, to the forehead. Make sure you know these, they are on your test. So if it's not working on the finger, somebody has shivering or a fake nail and we can't get a good reading, we can put a different type of sensor. It's a sticky one, like a piece of tape that wraps around the toe, the earlobe, the nose, or sticks to the forehead. Okay, never use an arm that you're doing blood pressure in to check, don't put this on the arm of somebody that's getting blood pressure in the same arm. You won't get an accurate reading. Always keep an eye out for any wounds. And you have to have a good reading. The reading, when you have it on correctly, You'll see it up and down, like bouncing, like little power strip that's basically saying it's working. Okay. So you cannot give oxygen because it's a drug. You can't put it on. You can't take it off. So you're probably thinking, what? How am I supposed to help this person? Here's the things you can do. You encourage them to get good exchange of air, cough and deep breathe. Position them high in the bed. Followers or semi-followers is best, and encourage them to cough and deep breathe. If they need to, they could be in the orthopedic position, which is on page 444. You can see a man sitting in a recliner. He has a chair or a pillow behind him, and he has his bedside table in front of him with a pillow on top of that, and he's leaning forward, sleeping that way. That is orthopedic. Where a person has to lean forward to get good rest, and they prefer to lay forward and not lay flat. Okay? So you could do that for your person. You could also encourage them to deep breathe and cough, especially after surgery. When people have surgery, our lungs get very lazy from the anesthesia, and sometimes we run a very big risk of pneumonia or lung infection. So coughing and deep breathing is something you do a lot with your patients. If they have an incision and they're afraid to cough because it might hurt, you give them a pillow to hold against their incision and then tell them to cough. Okay, when you encourage the deep breathing, you have them sit up on the edge of the bed or sit tall in the bed and tell them to take a deep breath in through your nose, then hold it, and then out through your pursed lips. So it's in through my nose, out through my lips. Okay, there's a picture of that on page 446 of your book. It shows you how they breathe in. They inhale through the nose, they exhale through pursed lips. You need to know that for your test. So if you're going to encourage your person to deep breathe, that's how you get them to do it. And you also need to know in the green box on page 445, if the person's going to cough and they're afraid of their incision hurting, you can give them a pillow. Okay. Here we go again. You cannot give oxygen. We said it enough times. So how do we give it? So the person is too low. Their oxygen level is too low. We tried coughing, deep breathing, changing positions. It's not getting better. I have to call the doctor and get an order. He tells me how much oxygen to give, how to give it, like through a nasal cannula, through a mask, through a ventilator, and when to give it. Some people will need it all the time. Some people might just need it. It might say, 2 liters per nasal cannula when short of breath from activity. So when she's up and walking around, she gets short of breath, I gotta put her oxygen on. Okay. There's two common things that we use to give oxygen. One is the nasal cannula. There's a picture of that one on page 448 of your book. The nasal cannula is in figure 30-12. Again, a nasal cannula, it has two prongs that go up inside the nostril of the patients. Then the tubing traces alongside the cheekbone, loops behind the ears, and is tightened at the neck. Your job as a CNA is you cannot take that on. You cannot put it on. You can't put it off. But what you can do is check the skin around the tubing, around the ears, around the cheekbones. Make sure there's no pressure sores happening because they could be tight. And you can encourage that person to cough and deep breathe. If the oxygen is shut off, you cannot turn it on. If the patient says it's too loud and I want it off, you cannot turn it off. Okay. The nurse in the care plan will tell you how much oxygen the person's getting. That's called a flow leader, or the flow rate. So when I tell you Mr. Anderson's on oxygen, you're like, how many? And I say 2 liters via nasal cannula every time he's up to the bathroom. So that means every time he gets up to the bathroom, we need to make sure he has nasal cannula, the thing in his nose to get oxygen. Okay. If I say 2 liters, you should be able to go to the device and look and see that it's on 2 liters. If it's on 4 or 5, you cannot lower it. You need to let me know. If it's supposed to be 4 liters and it's only 2 liters, you let the nurse know. You cannot adjust oxygen. You cannot give it. You cannot adjust it. But you can always check to make sure the rate is correct. Okay. So let's look at some of these things. So this is the flow meter that we're talking about. It hooks into the wall. So this is a oxygen unit set up like in the intensive care unit, the OR. In the hospitals, oxygen is usually built into the wall. And then a nurse just pushes this device in called a flow meter, and then the oxygen starts to come from the wall into the tubing to go to the patients. When I say the person's on a certain amount of liters, you could see this guy's not at 3, he's at 4 liters. There's a little ball in there. So he's getting 4 liters of oxygen. So that's when I say if the person's at 2 liters, you should be looking and make sure the ball's here. If it's down here, it's too low, tell me. If it's up here, it's too high, tell me. Okay, so that's a flow meter, and it measures the oxygen, or it gives us how much we're giving per person. That's the flow rate. Okay. This one here is just a portable O2 tank. You've probably seen them. O2 tanks we are not using very often anywhere but institutions, just because they're a safety risk. It's gas in a can. It can very easily, if it tips over, explode. Okay, it's kind of dangerous, so we really only see them in the hospital settings now. Instead, we're seeing other things like this. It looks like a karaoke machine. It's called an O2 concentrator. This is very common for our patients in a nursing home. And what happens is the oxygen tubing hooks into this little machine. The machine is plugged into the wall, and it kind of, when it turns on, it goes and hums. It uses the oxygen that's in the room. The machine sucks that O2 in and then clarifies it and gives it back to the patients. Okay, but there's the flow meter on the side. So that's a concentrator. The concentrators have to be plugged in. So if your person's in their room and they want to go out to the dining room, you either have to unplug the concentrator and roll it out with the patients, or maybe put the patient on a different type of oxygen, like this one. It's called a portable oxygen concentrator or liquid oxygen. The tubing hooks here, these are very lightweight. They weigh like 3 pounds. They usually have a strap and a little black bag, so they carry it like a purse, but it's a way to move around and still get oxygen. Much easier than those big tanks, okay, or this big like pop of a thing. All right. Here's your nasal cannula. See how it goes in the nose, across the cheekbones, behind the ears. Make sure you're checking the cheekbones and the ears for breakdown, underneath the neck. And there is a mask. Remember, in closing, you assist the patient with oxygen. You do not give oxygen. Okay, you cannot adjust the flow rate. And anytime something is not looking right or there's an error, you let your nurse know. If the patient is having a hard time breathing, you let the nurse know. You can do these things. You could check the flow rate and let me know if it's too high or too low. And if my humidifier that hooks to the oxygen is not bubbling, you see it's just laying there and there's no bubbling in the tube or in the container, you need to let me know. Okay. So I'm going to show you a humidifier really quick. So on page 449 of your book, there's something that looks like this. It's a picture of it, a flow meter. Okay, so this is a flow meter. It tells us how much oxygen a person's getting. It delivers the oxygen to the person. Sometimes people will say oxygen is very dry and it causes headaches or sinus problems. So we hook a little bottle of water onto here to humidify, to make that oxygen a little moist for the person. If the bottle is hooked there, it looks like a little like bucket of water. You can see it on page 449. If that's there and there's no bubbling going on where the water is, you need to let the nurse know because the humidifier is not working then. Okay, we are done. If you guys go into materials one more time. Module 3. 25 to 30. Sorry. Here's those videos. There's videos on a person doing Kuznel breathing, doing chain stroke breathing. You guys can watch the videos on your own. I just want to show you their YouTube videos. Okay. I'm going to come up in a minute, I hope. So this one kind of shows you the breathing pattern using the waves. Okay, this one shows you how pulse ox works. This video shows you what it's like to have oxygen at home. I'm sorry, what it's like for a person to be on oxygen. Like he tells you a story of what it's like for him to have oxygen for the rest of his life. And this one is telling you how to set up oxygen or use that concentrator that you'll see in a nursing home a lot. Okay, and how the person basically can have that at home. So these are good videos for you to watch so you understand what it's like to have oxygen. You understand what it's like to use it in the home. and you know what a pulse ox is. And this one will tell you about the different types of breathing. I'm going to Google one for you really cool. Kussmaul breathing is where they breathe super fast and the person's in distress. So if you watch this little guy here, so you see how he's going, he's a little young guy, I think he's 10. He's a diabetic. His blood sugar was too high when he went to bed. When his mom woke him up, this is how he was breathing. And it turns out this all kicked off because he has an infection in his mouth. And when diabetics get infections, their body quickly has a hard time functioning. So he's having breathing problems here. Okay, and then let's see if I can find a chain stoke for you. Here's what a chain stoke person looks like. This guy here. Again, chain stoking, they look like they're not breathing, then they breathe fast, then slow, and then they stop again. So if you watch him, nothing's happening. It looks like he's not breathing. And there it goes. He's starting to breathe again. But it's a fast breath. And now it's slowing down. Very slow. He stopped again. He's not breathing. Not breathing, not breathing, not breathing, not breathing, not breathing. And there he goes, fast breathing again. Slow breathing. No breathing. Okay. All right. That is it for chapter 30. I will do a quizzes to help you guys review. It will be posted sometime Tuesday afternoon or Tuesday night. It'll be a great way for you to practice. It's like a practice run of the test that you'll be taking on Saturday or Wednesday at home. So I will do a quizzes, Q-U-I-Z-I-Z-Z, for the chapter 25 and 30 tests that you'll be taking on Wednesday. And you can take that quizzes as many times as you want, and that will help you prepare for the test on Wednesday. Have a good day, guys.